want to welcome everyone to the first webinar in the Quality Improvement Center Spotlight webinar series, Collaborating to Implement Prenatal Plans of Safe Care. We're so excited to be able to highlight the work you all are doing in your communities and provide a space for you to learn from and with each other. So before we begin, we do want to acknowledge that the Quality Improvement Center and this webinar are a program of the Administration on Children, Youth, and Families, Children's Bureau.
Magistrate Edgar or any of your teammates, tell us a little about your program, sort of how you got to where you are now.
Sure. So when we first started the QIC site, we have always, or QIC work and doing our action planning, we really always envisioned two kind of parts to our grant. So we have the court part, which included our family treatment court, which I do preside over, and then we also have the community side. So I'm going to talk about the court side, then I'll give it to Kim to talk about the community side a little bit. But really with our court side, we have, when I took over the family treatment court, and I was even involved with the planning of, in 2005 of creating our family treatment court. And the way ours was and everyone else's was created was really under that adult model. And it included jail time, and it was very sanction-based and very, check boxes, you have to do this and this. So, and we knew it wasn't working really great. It was working, but not great. And so we knew we wanted to change it, and this grant gave us the opportunity to do that. We also really had envisioned, prior to the grant, we had a safe court, which is, I forget what it stands for, but it just stands for something. And it was really our pre-file court. And so it was cases that came in, it was heard by a hearing officer that the court contracted with, that it was based off of the same model as the family treatment court, but it was the unfiled cases. And we really wanted to, what we wanted to do in our action planning was to combine those two courts so that we just have one family treatment court rather than separating them out into whether they were filed or unfiled. And so that was really what a lot of our planning did. We also wanted to make it more family-centric. We wanted to take the jail away. We wanted to make it more incentive-based and try to get people more engaged, make it really a team effort. And so that was what our action planning was really about. So as part of that, what we did was kind of, we gathered a lot of community members and had a bunch of meetings and work groups and really started to collaborate with them and not just have them come in and say, what they thought of the program, but we really wanted to hear from them, and we really wanted to know what will work with this population, what do we need to do. And so that's really kind of how we started with the collaboration. We brought people in and had those discussions and started talking about it. And then once we started working on, they were doing the community side at the same time, but once we all kept meeting together and tried to collaborate and try to figure out what would work. So originally one of the parts of, and why we included the enhancement of the family treatment court was not only did we want to combine those two, the unfiled and the filed, we also at some point wanted to have it so that cases that weren't involved with children's services could use the family treatment court as a resource as well. We really wanted it to be part of the continuum of services and be able to help those families prior to even CPS being involved, or those private filings that we have all the time, that courts have, that we could incorporate some of those same things that we do in family treatment court with those cases that are not filed. So that was really kind of what we wanted to do and try to work on, and we saw a need for community side because there's all those cases of children that are born substance exposed or affected, but like maybe the mom is on Suboxone or something like that. And we saw a need for it to be not child welfare involved. And so that's kind of where the community service part came in and what we discussed with regards to that side of it.
So when we looked at the community readiness with our partners and for this population, we were ready. So we had done some work prior to the QIC grant of gathering community partners that were working with pregnant mothers who had substance use disorder, and we decided as a community we wanted to come together to look at service gap areas and how we could effectively serve this high-risk population. So what we needed to do is really look at our community protective factors. When we're looking at early intervention, we're looking at protective factors, and we do a lot of focus on individual and family protective factors, but this project allowed us to really focus on community protective factors. And we decided as a community we were going to adopt a vision for every child to raise awareness and commitments to support safe, stable, and nurturing relationships environments. And that would be for every child in our community. And we wanted to promote the community norm that everyone was responsible for this goal. So by adopting that norm within our community, we were able to gather those partners that were focused on prevention and early intervention and serving mothers and infants born substance exposed and affected. This QUIC grant, though, allowed us an opportunity to have more meaningful and intentional conversations outside of just the commitment to make sure that every child in our community was safe and healthy. And those conversations focused on our systems and our process of how we were going to work together to serve families. The grant also provided an opportunity for us to have training around the impact of substance use disorder on infants and family systems, and training on how to roll out effective plans of safe care within our community. We were able to establish a resource guide, and we were able to really work together as a unit to provide those resources to providers. From an early intervention standpoint, we were able to effectively expand our referral sources. So we practice a no wrong door policy on intake, which means that any family within the community that needs support from an early childhood perspective, they can call us, and we are going to find the program that is most appropriate for their family and their child, as well as eligibility. So the QUIC grant allowed, with the invested focus on early intervention from CPS and juvenile justice, to really enhance that no wrong door policy for children.
Right.
And in that, CARA also happened, which really helped us come together with a focal point on what CARA was and how that was going to determine systems and processes for substance exposed and affected infants. And Stacy really has the CARA background and how we incorporated that into our community.
So taking us a few steps back, even before our agency and the Corps and the community was involved with the QUIC grant, Fairfield County Protective Services was aware of the CARA law passing, and we knew that it was impacting the community. We knew it was going to impact our screening decisions and the way that we would screen in referrals and whatnot from our community. And so what we did is, once we received information about CARA law passing, we started taking that information to groups that were already existent within our community. So we had a perinatal leadership group that was already in existence, and there were key stakeholders that were part of this community group, and we really used that as really the arena to start sharing information about CARA law and really starting to have some of those conversations that we need to really all come together as a community to figure out a plan of how we want to address this. And so that's really where it all started. In the meantime, we started enhancing our own screening practices within child welfare and making sure that our screeners were really asking the right questions, the most appropriate questions, detailed questions, to try to gather the most pertinent information about plans of safe care, and really starting to educate the community and mandated reporters on what plans of safe care were and what we as an agency needed to make an informed screening decision at that point of the decision needed to be made. We started having communication with our local hospital on, this is what a plan of safe care is. This is information that would be helpful that your case managers would gather at the time of the birth of the child. And so that's really where it all started. And then the QUIC grant, we started that within our community, and that's kind of where we took off, and everything expanded from there.
Can you tell us a little about your program, Karma, what you've done through QUIC?
Yes, absolutely. So when we first started and applied for this grant, we had really focused on our family treatment court within the courts and improving. We were serving families that had infants with prenatal substance exposure or were pregnant, but we didn't have a coordinated or specific kind of plan to how we would work with those families, and we wanted to hire a recovery support specialist to work with these specific clients, so that was our original focus. But as we started working with QIC and getting all of this information at all sites and the best practices information, we really thought we needed to expand our vision. So we had originally said, well, we're really interested in prevention, but we're the core, I don't really know how we can do that. And so we had said we wanted to look at starting at the hospital when a baby was born, and DCS, child welfare, was going to be involved in those families' lives, and we didn't know what that would be, but we wanted to do some kind of pilot at the hospital. So to start, we built our SHIFT collaborative. So it stands for Safe, Healthy Infants and Families Thrive, and we took the guidance really based on a lot of the work that Sally Borden and the CHARM Collaborative had done in bringing the community together, and started to have meetings about what should we do. And during that process, we got Denise and Tara on the team over a course of 6 months, probably a little at a time, and we started to say, you know, I really think there could be more work we could do prenatally. Why are we waiting for the birth event to help these families? And so we started to look more globally at the issue, and because we had public health and we had a neonatal nurse practitioner who knew that field and knew the medical side, which was something for the court that we had always struggled to reach those communities, especially in our infant toddler work. And so one of the things that I think really helped us is bringing in subject matter experts. So we started with Dr. Ira Chasnoff, and we offered free training. So people showed up. I think we got over 200 people from the community, multi-systems, from a variety of disciplines involved, and it really opened the door to get people interested in working with us. And it was really a talking point, like, please, we're going to do this training. Please tell us more about what you're doing, and we'd love you to go to this free training. And then we also brought in Dr. Mishka Turplin and Sally Borden, and that was really helpful in opening the door to these more prevention lens, I guess, is how I would word it. So, and that's how we kind of got to the place that we are now with our prenatal coordinated care pilot, which I'll talk about in a minute. So I'll let Denise talk about her experience.
Sure. So as a manager in public health, I oversee 4 programs. They all have home visiting as a component in them, and 2 of them serve women prenatally. So Healthy Start and Nurse Family Partnership are the 2 programs at our public health agency that do that. I've worked as a nurse home visitor as well as being a manager, and what I experienced is that women with substance use disorders who become pregnant live in fear their whole time during pregnancy of that use being discovered or of losing, having their infant be removed. And we know that maternal stress can be associated with poor birth outcomes, including preterm birth, infant mortality, and low birth weight. And additionally, that psychosocial stress during that time can increase the use of substances as well as the chance of relapse. So I'd not worked with the courts before this project, and when I was first asked to join, I just wasn't sure whether public health would have the same objectives for families as the courts would. But what I found out was that the principles that are important to us in home visiting, trauma-informed care and protective factors, early intervention, and the goal to keep mom and baby together were shared by the family treatment court and the other disciplines that were represented on the collaborative. So I'm really excited about this program, and I think that it can have a really huge impact with that prenatal focus.
And I, like Carmen said, I am a neonatal nurse practitioner, and probably 4 or 5 years ago, we started seeing all of these babies coming into our neonatal intensive care units withdrawing. And I'm not proud to say it, but I was that person, and many of my peers are. of the ones saying, I cannot believe we're going to send this baby home to these families. And I will say that after I think I was at a training, maybe with Karma, and they brought up adverse childhood experiences, I will tell you most medical providers have never heard of them. When I heard about that, I just immersed myself and learned so much about them that I was like, okay, now I cannot believe that we're not sending these babies home with these families. And Hushabye Nursery, just a little bit of how that started. Being a practitioner, I took care of these babies in the hospital, and really from nurse to nurse, doctor to doctor, there was no consistency as far as how we'd care for them and the babies. And we were even worse with how we cared for the families. We were very judgmental. I had no idea that opiate use disorder or substance use disorder was a chronic illness. I didn't know that it was a brain disease. I truly felt like it was moral failure. Now I've learned a lot, but that was really how I felt. And as I'm learning more and more, initially our plan was, let's save the babies from the neonatal intensive care unit, and we're going to take them out of the neonatal intensive care unit and put them in a place specifically for babies with neonatal abstinence syndrome, which is Hushabye Nursery. Now our whole model has really evolved to the point of really it's not serving just the babies, it is the whole entire family system. So it has taken us forever to be able to open the nursery baby center of care, which hopefully in April will be open. But in the meantime, I really think that all of this has just rolled out for a reason, because our program is so much better in being that we start prenatally and we follow them all the way through, and the outcomes that we're having have been amazing. Just by really understanding opiate use disorder, MAT, neonatal abstinence syndrome, trauma-informed care, all those different things, and then being connected with home visiting in the courts, totally foreign land to me, but amazed that really we all have the same goal.
Yeah. And so over the course of, I think, probably 9 months or a little bit more, we started saying, we want to do this pilot in the hospital, but I think that's too late. Or maybe not too late, but why are we missing this opportunity during pregnancy if we have families who are engaged and could benefit? So instead, we're still focused on how do we make things better at the hospital event, but we really said we need to push it back. We need to go more upstream, and so we all together met many, many times to develop the prenatal coordinated care pilot. And so what we're going to do, and we haven't officially launched it, we've just spent all of this time really developing it, and then we have Tara's work as an example to us of how it could be done. We wanted to say, how could we get all of these different agencies we had lots of agencies, Maricopa County is very large, doing great work, and none of us were talking to each other. So how could we make sure that for these families that this care is coordinated, and that we're preparing families for what to expect at the birth event, helping get them into services and referrals as soon as possible during the pregnancy instead of waiting till the birth event. And so that's where this model that we are going to talk about today came from, and it's really designed to help any provider. So if it's home visiting, if it's a nurse practitioner like Tara working with them prenatally, if it's family treatment court who are working with pregnant mothers, that they have something that's very laid out about how they could work with these families, and using a prenatal plan of safe care, which we're calling the prenatal family care plan, as guidance towards how do we make sure all of these needs are met for the family.
I'm wondering if we can take a step back and talk really briefly about how the court piece changed, both in Fairfield and in Maricopa. Magistrate Edgar, do you want to talk a little bit about how the court's role has changed from actually doing treatment court, but also assuming a much larger kind of leadership role in the community around this issue?
Sure, thanks, Gail. So and I'll tell you, when we first started this grant and Gail kept asking me, what is the court's role in plans of safe care? I'm like, Gail, we don't have a role. It's before we get it. I kept telling her, I'm like, it's before we get it. What are you talking about? If it fails, we'll get involved, right? But like, we can bring people to the table. That's all we can do. So we've had that conversation several times, but clearly that's not what it is, right? So we have definitely taken a larger role in the whole, I think, whole community side, and we were able to. So just to back up a little bit, when we first started, the only time we really heard about plans of safe care is, like I said, when they failed, right? So they would come in. It's when CPS or our Child Protective Services would have to file because there was some protective factor missing or something was going on, and so they would file and it would come in front of us. Other than that, we really didn't have any involvement with anyone prenatally, because number one, we don't have jurisdiction if a baby's not born, and we really, unless there's older children. So a lot of times we would have that where there are older children already involved with us in some manner, and then people would get pregnant. So we would have involvement with that, and we'd be talking to the parents about that and things like that in our court reviews. But really, other than that, we didn't have much involvement, except, I mean, we did have state court, which was a pre-filing, but it wasn't really prenatal. So, but since we've been involved with the grant, and as our relationships have developed and we've included a lot of people, I think we have been able to change the role of the court with the whole community and the team.
Magistrate Edgar, I'm wondering if Kim or Stacy might want to briefly look at the Plan of Safe Care process chart and talk a little bit about that. So folks it's pretty detailed so folks can understand kind of how the process works.
Sure. So from the child welfare side of things, mandated reporters, we always encourage mandated reporters or community members or whoever it is to call in concerns to our agency, whether or not there's a suspicion or if they have belief or just an inkling or an idea that there's concerns of abuse or neglect for any age of a child. Really, the way that the process chart is if there's notification and it's screened in to our agency and it meets that criteria guidelines, our child welfare workers will then take the lead on the development and the monitoring of the plan of safe care for that infant who has been exposed or affected to substances. So that's the one side of things. On the other side of things, if it's screened out and it doesn't meet our criteria, we have to assure that there's a plan of safe care that's in place for that infant, which is why the communication, the education, the collaboration with our community is so crucial. And what we are lacking before this grant really kind of pushed us in that direction is making sure that, our community providers are working with these women who are pregnant earlier on in their pregnancy and linking them with treatment and working with them on their treatment needs and intervening earlier with them, because when that child is born, that's when our agency starts to be able to intervene. And if we have an adequate plan of safe care in place, it may allow us the opportunity to either screen out that referral and not open up an investigation, again, depending on the criteria that's presented to us, or, our intake worker is 5 steps ahead of the game, and when that infant is getting ready to be discharged from the hospital, we have all of these other things in place. The treatment needs of the infant are being addressed, the treatment needs of the family are being addressed, they have a support system, they're linked with what they need to be linked with, and that really ultimately increases the outcomes for that infant. And ideally, in a perfect situation, that infant could be discharged to that mother. And really, without those prenatal plans of safe care in place, that increases the likelihood that we wouldn't have all of those factors in place where we could actually have that take place, which again is why it's so important to make sure that we're really engaging our community partners in the entire process. Well, what we've incorporated within Fairfield County, because we had to figure out some type of system or plan of how we were going to communicate with our mandated reporters of whether or not we were involved or not involved. Because again, if we're involved, our caseworkers take the lead on developing this plan of safe care. But if we're not involved, we have a plan of safe care coordinator in our community, but we needed to somehow be able to get that information to that person that we were not opening up a case. And so what our screeners are doing and supervisors at our agency are doing is that if we have a mandated reporter who's calling in that concern to our agency and we're screening out, so we're not opening it up for an investigation, we are then calling that mandated reporter back in the moment and letting them know the decision. that we will not be opening up a case, and giving them information about our Plan of Safe Care coordinator and encouraging them to reach out and to make a referral to her. But I'm going to go ahead and let Kim kind of talk on the community side of things, because again, none of this is going to work unless we have buy-in from our community and that our community is working with these mothers earlier on in their pregnancies.
Thanks, Stacey. So I think Stacey did a nice overview of really looking at this flow chart and process chart. When you take a look at the top of the process chart, what Fairfield County has said as a collaborative team is that anyone working with a mother could create a plan of safe care. And so this really helps you look at the top, who our partners are around the table, and then looking at when those disclosures are happening. So I think we've all mentioned that hopefully the disclosure is happening prior to delivery. That's when we want to really look at a plan of safe care to improve the birth outcome and the health of the mother. So oftentimes those disclosures might be happening with already a trusted relationship that is built. So that could be in a home visiting situation. It can be in a behavioral health situation. It can be in a primary health situation. So we wanted to be able to equip providers with the knowledge of what a plan of safe care might look like, because that trusting relationship might already be present with the mother, and then that plan can be developed. So the process chart is giving options to community partners of who develops the plan of safe care, and then how those are funneled through our system with our coordinator and follow-up.
I wonder if we could go to Maricopa. Karma, could you talk briefly about the court shifting role, but also the expanded plan of safe care that you all have developed to really cover the continuum for families?
Yes. So when we first started this, I think we had a similar question as Fairfield, is where does the court fit into all of this? So we had our treatment court, so that was really our focus. And really what we ended up landing on is the court is invested in the idea that if we don't need to see a family, we don't want to see them. But the court, by our nature, is responsive. So we need to have jurisdiction. We need to wait for the baby to be born. But there's nothing that says we can't reach out to our community providers and use our position of leadership to bring people to the table. And I think that's where we've been the most successful, is really bringing people to the table who are doing the prevention work. So the court isn't the one doing the prevention work, but we care about what happens and how this is all laid out, and so that we can have a voice in that discussion and let the prevention people do their work in hopes that we don't have to see them in court, but if we need to, then we'll be prepared for that side of things. And so what we ended up doing, in Arizona we have some different things than it sounds like in Ohio. Pretty much every call that comes in to the hotline is investigated, and so we don't have this option of the screen in, screen out. You know, that's not how it works here. And so when DCS, the Child Welfare Agency, Department of Child Safety, becomes involved, they do the infant care plan. That's what our state chose to call the plan of safe care. But there's some limits to the policy and the work that the Department of Child Safety does with that. So it starts at the birth event, and it's done by the investigative worker at the beginning, and then if the case goes in-home, then an in-home case manager will continue to work on that plan for a year or as long as the family is engaged with child welfare. But we were seeing these cases in family treatment court that were mostly out-of-home. And for out-of-home, the policy dictated that after 3 months of the child being in stable out-of-home care, they no longer needed an infant care plan. And we felt like we were missing something for our family treatment court parents, that they weren't able to engage in this plan or even have a plan under the policy for the infant care plan. And so we developed, it's kind of, I like to think of it as a sandwich. We developed a prenatal plan that our community providers can do in hopes that whatever we can do to prepare the parents before the birth event is good. And then DCS will be involved if they become involved, they're going to do the infant care plan, And if they come into family treatment court, then they'll have that end plan so that it could all kind of work as a continuum for that family over time.
Excellent. I'm wondering if you could talk just a little bit about the flow chart that you have that's up on the screen right now.
Yeah, so basically what we did with this is say, this is going to start with our pilot, and we decided we want this. Eventually, the goal would be if things go well and we can show good outcomes, that this becomes a standard of practice across the state. That's really our goal. But to start out, we need to show that it works, so we're going to start small, and that's why it's our pilot. We've got a variety of different agencies who are going to be involved, and what we're looking at is no wrong door access. So as soon as we identify a pregnant parent, we're going to work them into this process no matter where they come from. So if they're going to the behavioral health provider, if they're coming through TARA, or they're working with public health or a home visiting program, if they're working in family treatment court and become pregnant, any of those, our MAT provider can start engaging in this process. And when I say pregnant parent, we also want to include the father if the father's engaged. So we are working with the mothers primarily, but we're not excluding fathers from that process, but we really want fathers to be a part of it as well. And then we're really looking at in the plan and the idea of it's just a piece of paper if you don't fill it out right, that's all it is. We'd want it to be meaningful to the family, and so it's about the family being able to know about resources and services available as soon as possible, as soon as we identify them, and helping them engage into those services. So do the parents need substance use disorder treatment? Do the parents need to have information about neonatal abstinence syndrome and how to prepare themselves for that? Do the parents need to know about safe sleep? Do they need family support? Do they need to develop that kind of thing? Do they need education on medical needs or some of these great things that home visitors do in the home? And making sure that for any one of our providers that are working with the family, that we don't expect one agency to be able to do all of this work. So if we have a family treatment court parent who is pregnant, we're going to refer them for home visiting. If it's opiate use, we're going to refer them to work with TARA so they can be prepared, even if they're on MAT or not, they can be prepared for these symptoms that they're going to see in their baby, and that we can then prepare that parent before the birth event, but that it doesn't stop at the birth event, that we're going to continue to work with that parent engaging in this treatment for the child and their own treatment all throughout this process.
How does a mom get referred to the Plan to Safe Care coordinator, and how's that working out? I think you mentioned that that due to some Ohio laws, that that information gets passed on to the mandated reporter, then hopefully for screened out family, screened out case, that the mandated reporter would give that information to a woman in order to connect with the Plan of Safe Care. Can you talk a little bit more about that?
Yes, absolutely. So within the state of Ohio, based on our screening guidelines, and I'll give a specific example. Let's say mom is using marijuana throughout her entire pregnancy, and we know that infant has been exposed prenatally to that substance. Okay, so at the time of birth, let's say that mom is positive and infant is negative. Per our screening guidelines, that would be an example of something that our agency would not have to screen in and investigate. In that situation, because it's screened out, we'll know that infant was prenatally exposed to that. We were trying to figure out how do we summon information to our Plan of Safe Care coordinator. So in that situation, within the state of Ohio, we are able to share specific information to our mandated reporter. So again, they have to be a mandated reporter, but one of those pieces of information that they're entitled to receive is whether or not we screened in that intake for an investigation, or if we screened it out and it's just housed within our statewide system as historical information. And so this was our mechanism to get that information to the Plan of Safe Care coordinator, because at this point, if we're screening out, we don't have an open case, we don't have a release of information to share that confidential information of that family. And so this was kind of our way to get that. Now, the Plan of Safe Care coordinator could also be referred from other providers as well on the community side of things. And so Kim can kind of talk about how her team, for example, refers cases and situations and mothers to our Plan of Safe Care coordinator as well.
So, we've talked about the disclosure could happen prenatally within the trusted relationship. So, at the Plan of Safe Care is developed with the mother and those that are working with the mother currently. So we've shared some other examples. It could be WIC, it could be the behavioral health, it could be a home visiting provider. And at that point in time, we're talking with mom about our role as a mandated reporter, about the Plan of Safe Care coordination system, and we're really looking at a family-centered, strengths-based approach and discussing with mom where we can go with the Plan of Safe Care and how that may work. If mother agrees, we're doing a release of information, and then that is forwarded on to the Plan of Safe Care coordinator, who would be, the family would be staffed in a cluster staffing, which is where all the providers are around the table, including CPS, and we would take a look at the plan and then put things in place that we need to where there are gap areas, or even do some future planning around the birth event. If the case is screened out through CPS and that decision goes back to the mandated reporter, it's our goal that all of the mandated reporters within our service area understand Plans of Safe Care, understand how they can develop a Plan of Safe Care, or make that referral to the coordinator, who would then do outreach to the family and to the service providers to develop a Plan of Safe Care. So that's why that community training is so important. So if a case is screened out, we still want to be able to have healthy birth outcomes and healthy families.
Thank you. There was a question. The Plan of Safe Care coordinator in Fairfield is employed by whom?
She's employed, so she's paid by the QIC grant, but she's a county employee, but she is kind of split between the court, because we are the grantee for the QIC grant, the court and the Family, Adult, and Children's Birth Council. So it's a dual role, kind of.
And I can talk a little bit, Ken. We've started talking about sustainability, so I think, you know, what we're looking at is that the community believes that this Plan of Safe Care coordinator is crucial to facilitating referrals and support systems and, you know, helping bring together service providers for the family. You know, our community is saying right now that's important. So we're looking at how to sustain that role. So communities can take a look at a maternal and child health grant. Prior to QIC, when we were looking at perinatal needs in mother, the coordinator of the perinatal leadership group was paid out of maternal health funding through our local health department. The Adam H. Board also provided some funding for that position. United Way is an option to look at funding for that, as well as state, local funding and foundation funding. So really what is not billable is that this whole community collaborative piece. Case management that the coordinator might be doable could perhaps be billable, but we have to find funding for the coordination about bringing the agencies together, because that's not necessarily a billable piece. So those funding sources might be beneficial to the other communities in looking at how to staff that.
So we are out of time. And so I'm going to wrap this up. First of all, I want to thank you all for your participation, for your sharing what you're doing. Most communities, it's still a work in progress, and the amount of progress you've made in a relatively short period of time, recognizing that you initiated this work prior to your involvement in the Quality Improvement Center for Collaborative Community Court Teams, but it's evident the progress you made. When we do presentations around plans of safe care, around addressing infants with prenatal substance exposure, we have a slide that says no one agency can do it alone, and you certainly exemplify that with the array of partners, reaching out to other community agencies and supports, to having plans of safe care and supports for women, families, in particular prenatal, pregnant women and postpartum women that are not just child welfare centric, as I mentioned earlier, and certainly this goes way beyond just a child welfare agency, and you guys exemplified that very much. So we want to thank you for that.